to answer a few questions. So may we start with Professor Hellings? And actually, this is a question for everybody. And the question is, do we have actual biomarkers in everyday clinical practice? Because, well, in my unit, we use eosinophils in the blood or in the tissue if we have measured this number, and total IgE. Do we have anything more than these to use as biomarkers to see if it is a Th2 inflammation or not, or to choose ideal treatment?
Maybe I just can.
Yes, of course.
Or Peter, you start. I don't know, as you like.
Well, it's up to the chairman to divide the tasks.
Okay, good.
May we start with Professor Hellings, because he was the first man to talk about biomarkers. Thank you.
Well, thank you, Tim. From my perspective, we should stick to kind of consensus. And there is EPOS consensus, there is euphoria consensus, and there are 3 biomarkers that are really valid for defining type 2 inflammation. These biomarkers can be applied by any clinician, meaning blood eosinophilia in the tissue, or blood IgE. Apart from those biomarkers that are cheap, that are available to any clinician, we might think of TSLP, we might think of many other cytokines, either in the tissue or in the blood. But so far, these biomarkers are very interesting for research purposes to fine-tune future treatment options and prediction of therapeutic responses. But for now, we should stick to what is available and what is relatively cheap and easy to access for any of our colleagues.
Fine, thank you. Professor Bucket, you want to comment?
Well, just a comment. We do not have biomarkers to help us select the biologic concerning my talk here.
Mm-hmm.
Unfortunately, if we see that this is a type 2 immune reaction because the eosinophils are increased, or we have eosinophils in former samples, then we are still free or unguided in terms of what biologic we would use. What you have to do then is really compare, as I said, the responder rates and the maximum.
That's fine, thank you. So we carry on to Professor Douglas. Richard, is there any clinical application on our current knowledge on microbiome? Or maybe do we see any possible application in the near future?
Look, Tim, that's a really good question. The more I have been involved with microbiome research, the less I am certain about the role of antibiotics, which I see as a potentially cutting a swathe through our normal microbiome and perhaps not removing the pathogens as we perceive them. I personally think that we're a long way away from being able to manipulate microbiomes in a favorable way. The real difficulty, as I hope I managed to illustrate, is that, frankly, just about everybody seems to have an individualized microbiome, and that microbiome may not necessarily stay the same over a period of time. So the concept of, as it were, taking a damaged or pathogenic suboptimal microbiome and then in a long-standing manner converting it into a favorable microbiome, I think it's intellectually really appealing, but I'm not absolutely sure it's going to be easily physically achieved anytime soon. So I think we should keep plugging away. There's something there. I know it. It's just it's way, way, way harder than I thought it was going. I ever would have thought at the beginning.
Fine. Thanks very much. Okay. We don't have questions for Professor Del Godio. We go on to surgery, and we have a question. Is there a sort of clinical, sorry, let me read it again. About customization of the extent of surgery, Alki. Is there any classification or point system, the question is, to decide on the extent of surgery?
That's a really good question. Yeah, that's a really good question, Tim. And I don't think that we have a definitive algorithm for which surgery works. The reality is, if a patient has, Lund-Mackay 24 out of 24, and you do sort of limited surgery on that patient, they're going to fail. And when I say limited, I'm saying the lower sinuses. When you do maximal surgery on that patient, I think it then depends on their anatomy. So if they have narrow frontal sinuses, but they have a really high disease load in those sinuses, and you simply do what we call a full house fist, which is frontal antrostomy, frontal osteotomy 2A or 2B, and we clear all the sinuses out, there is a chance that those patients would fail also. And so that then questions, do you do primary drill outs, which is obviously a very, very controversial topic. And personally, I don't do primary drill outs at this stage. So it's really tricky, Tim, because I think there are so many factors other than the extent of disease that determines how well a patient does. Their compliance post-surgery with topical steroids, whether or not they have access to biologics, their size of their openings to their sinuses, all of that comes into play. But generally, the more disease, the more extensive surgery you're going to do. And that's probably the most sensible answer I can give you.
Yes, absolutely. Yes, we all agree, I think. Now I have a question of my own here. Can we talk nowadays, can we talk about failures or success of surgery alone? Because in the past, we used to divide the patients into surgery patients and medical treatment patients. But today it's a bit different because surgery is a part of the management plan, and it precedes medical treatment, which is usually topical medical treatment. So can we talk about failures of surgery today, do you think?
Well, I think, as I said, there are technical failures and disease failures. So the surgical failures
quite clear,
are the ones that we leave partitions behind, we leave disease behind. Whereas the technical failures, I don't think they're a surgical problem. These are patients who are failing because of their disease burden and are failing either due to lack of availability, lack of compliance to topical or biologic medication, or that they've got very severe disease. And even Prof. Bakat said some patients will even fail biologics because of their disease endotype, I suppose.
Right. Peter, you wanted to say something.
Thank you, Tim. I would not define a patient with persistent symptoms after surgery as a failure of surgery, because we did some trials, including 800 patients, where we looked at factors that determine the success of sinus surgery. And these were mainly occupational factors. If patients keep on being exposed to environmental triggers that are responsible for the chronicity and the perpetuation of inflammation, it may be one of the key triggers of chronicity of inflammation and persistence of inflammation beyond surgery. So I would not call it a failure of surgery. I would rather call it an uncontrolled patient despite surgery. And we are just about to publish a study including 600 patients where we looked at reasons for being uncontrolled after sinus surgery. And this is a topic of a lecture on itself. But there we define disease-related, surgeon-related, environment-related, as well as patient-related factors that all determine reasons why patients may remain uncontrolled after sinus surgery. And in most patients, we find 2 or 3 factors that could be given as a reason why there is uncontrolled disease even after sinus surgery. But this is just a short comment of mine, and sorry to jump on this discussion, but because I'm too excited about this topic.
Right. So I think we all agree on that. I have a very interesting question for Professor Bucket. A colleague here asks, do you have in your clinical practice patients who initially respond to biologics and then after some time they start not to respond, maybe because of autoantibody formation against this medicine, or this is something that sometimes happens in patients with severe atopic dermatitis. So do we have this sort of possibility?
Well, the point is, of course, we don't have yet a very long experience with biologics. Actually, most of us have experience with biologics in terms of studies, and that doesn't allow us to say anything about reapplying the same drug in the same patient, for example. If we have stopped treatment and they would develop polyps again. I know from the time in Sweden, in Stockholm, I was able to actually apply biologics 5 years earlier, that in the few patients, it's not about 100 patients I can talk, that we didn't see that. I haven't seen a responder who then, when continued with the drug, turned out into a non-responder. Of course, what you see is if patients get viral infections, polyps might flare up again. Infection might be, other reasons of inflammation may come up and blur the picture for a while. But that is, of course, that will come down to normal or to the situation before this infection before. So I haven't seen people developing monoclonal antibodies against the monoclonal antibodies. It is described in the literature in about 4 to 5%. I personally haven't seen a single case where these antibodies were also functional in the sense of that they sort of made these monoclonal antibodies not work.
Fine, thank you. So I understand there's a growing demand, at least from our side, the ENT side, rhinology side, for common guidelines for asthma and CRS. Do you think this is possible, Professor Bucket?
We have already elaborated on some of these aspects. At the moment, of course, this is more, from the rhinology side or from the asthma side. And of course, there are patients we have together. And I think that's an aspect we have to look more at. Very often, the patients I see, if they have severe asthma, so then they're treated by the pulmonologist, and then we just follow up. But we need to intensify that dialogue in the sense of that we are involved in the decision, for example, what biologic to give, because we do know that there seem to be not nearly equally effective in asthma, but there are really differences for the nasal polyposis part. So we need to be part of that selection process, and that is just something that comes with time. So far, I think it's just a few centers really using biologics for nasal polyposis.
Right, thank you. So before I close this session, may I ask Professor Del Godio, John, would you like to comment on any of the topics discussed?
Yeah, sure. So as far as the markers, we pretty much go basically on, we see a lot of eosinophilic disease where we are in the United States, in the southeastern United States, a lot of fungal sinusitis, a lot of AERD that has eosinophilia. So we use tissue eosinophilia. We really don't, unless we have significant failures, use serum tests with IgE and serum eosinophilia as much. And also that helps to direct our topicals, because topical steroids obviously are going to be much more effective in patients with significant eosinophilia rather than the neutrophilic disease. So, we go based mostly on tissue markers as opposed to serum markers.
Right. Thank you. So anybody else from the faculty, would you like to comment, make a closing remark or something? Yes, Peter?
If I may, I was nicely impressed by the topic on topical treatments, and I missed a little bit the baby shampoo story, because I heard so many times that if everything fails in a patient who had FES, you should add some baby shampoo to the local douchings. So I would like to hear your opinion on that, because I must admit that I just have 2 patients out of a large series in whom it worked. So this is just very non-evidence-based, but what kind of patients would you consider it? Either in none of your patients, or maybe in 1 out of 5,000 that remain uncontrolled despite anything that you have tried. So please share your frank opinion.
Yeah, actually, that's a good question. That was one of the things. There is no evidence on it, but I do use it periodically, and it's for the last effort when everything else fails, and especially when it looks like they have biofilms or they have significant crusting. And it's just a drop or 2 of baby shampoo in the irrigation. And it's not uncommon that I'll use it in addition to the topical steroid, all in the same preparation. The other thing is that since I do a fair amount of skull-based surgery also, and a lot of these patients have significant crusting because they have a wide open nasal cavity, over the last few years, we've been using some coconut oil also in the irrigation. And it really, in some people, it's extremely effective. Obviously, they smell like a tropical drink, but it actually works.
How about Manuka honey, Alki?
Yeah, there's no evidence on Manuka honey, and I personally have not used it. So I really can't comment too much on the Manuka honey. But I will tell you, the baby shampoo, the last effort it can be effective, as you said.
It may work in the patients of Richard, where the microbiome is being distorted, and with
Richard, do you have any experience with Manuka honey?
Only a little. I have actually tried it myself. It's appallingly horrible to put in your nose. And having had the first go, I haven't been encouraged. The evidence for its efficacy is not strong.
Okay. So thank you very much, all of you, for being with us, being so kind to accept our invitation and being with us. It was a great session. I enjoyed it very much. And I'm sure that the 1,081 people attending this session enjoyed it as well. Thank you very much. We are very grateful. Bye-bye.
Thank you, Tim, and thanks everybody. Bye-bye.
Thank you. See you.
Bye.
Bye-bye.